This is a video for lab preparation for abdomen. The structure and function with the abdomen quadrants that we're going to be talking about. There is, for your assessment purposes, there are 4 quadrants: right upper, right lower, and left lower. But when we talk about all the structures that are located in the quadrants or the areas of the abdomen, there are actually 9. So don't forget the epigastric region, which includes the stomach, and the hypogastric or suprapubic region, which includes the bladder. And so here's a picture provided where all these organs are located, because when we're assessing the abdomen, we're assessing for a purpose. So when you're preparing your patient for an abdomen assessment, you're going to make sure you have a drape, because we're only going to expose the areas that we need to assess. It's always suggested you would have your patient empty their bladder first, because assessing a patient with a full bladder can be very uncomfortable. And we're also going to ask the patient to try to relax their abdominal muscles. Some patients might be ticklish or maybe having abdominal pain. So having them resting on their back or supine with the knee slightly flexed when we do palpation is encouraged. We also ask that we do not have the patients put their arms above their head or tense the abdomen muscles because that we're trying to assess the abdomen and organs underneath the muscular wall. And we're always asking our patient about pain because we want to examine those painful areas last. If you examine the painful area first, that pain can radiate to the rest of the abdomen and skew your assessment. So when we're inspecting, we're looking for any striae or stretch marks, any scars or piercings. We want to make sure that they're healing and there's no signs and symptoms of infection. We assess for the color of the abdomen. We expect it might be paler than the rest of the body because there's not as much sun typically, but we're looking for consistent coloration. There may be abnormal findings such as bruises or redness, and you're going to document those in whichever quadrant they may be located. We're going to note vascularity, and there may be scattered veins that may be visible, but the veins are dilated or really prominent, as in ascites or abdomen distension. That is an abnormal finding. We're assessing for lesions or rashes. We know sometimes macules or moles may be located, but we wouldn't expect any rashes or anything like that to the abdomen. Just like any other part of the skin, we're going to look for any changes in those macules and petechiae or that spotty redness related to anticoagulants is an abnormal finding. When we inject heparins or Levinox, we do that in the abdomen. So a lot of times if you're frequently have punctures in the same place, that can occur. We're also going to inspect the umbilicus, and we're looking for it to be midline, whether it's inverted or everted, and if the umbilicus is deviated or if there's any masses, can indicate enlarged organs in the area, or fluid, scar tissue, or even umbilical hernia. So again, continuing the inspection, we're looking for symmetry. We're looking for any hernias or masses, and we can see that with deviation or bulges in the abdomen. We know a hernia is a bulge through the abdominal wall, and that can happen in the umbilicus, incisional, and inguinal hernia spaces. We assess for aortic pulsations, which is an exaggerated pulsation in the epigastric area. And we never palpate those because they may be abdominal aortic aneurysms. And we'd never want to injure your patient doing that. You also may see your patient's peristaltic waves, and typically only you can see this in thinner people, but if you can see exaggerated peristaltic waves, we may be looking at some intestinal obstruction. We expect your patient to be relaxed and breathing normally. If your patient's having pain or restless or grimacing or guarding against one side of the abdomen versus the other, that would be an abnormal finding. So when we're auscultating the abdomen, because we're always doing that before palpation, we do that to avoid any false interpretation of our sounds. We're going to begin in the right lower quadrant and go clockwise into all 4 quadrants using the umbilicus as the center. You're going to apply light pressure with your stethoscope and utilize the diaphragm. We're listening for 5 to 30 gurgles per minute. Any hyperactive sounds or borborygmus or loud sounds as the stomach is growling, depending on what's happening here. But greater than 30 sounds per minute, we would consider that hyperactive. And we see this sometimes with early bowel obstruction, gastroenteritis, or if your patient's experiencing diarrhea, things are moving through his belly or her belly quickly. Hypoactive bowel sounds are less than 5 per minute. And this we would consider this diminished motility, and we see this with paralytic ileus, peritonitis, or late bowel obstruction. We might even see absent bowel sounds with peritonitis. We have to establish the patient has absent bowel sounds over 5 minutes. So you would have to listen in that same quadrant for at least 5 minutes before you can report that there's no bowel sounds in that area. When we do light palpation, we're going to use our fingertips. 2 to 3 fingertips. We're going to palpate the non-tender quadrants first. We are only going to press 1 centimeter, which doesn't really even displace tissue. We're just feeling the surface area. We can minimize ticklishness or voluntary guarding by having the patient bend their knees and always avoid the tender areas till last. How do you know? You're going to ask your patient if they're having abdominal pain. So the expected finding is that the abdomen is non-tender, soft, no guarding, swelling, bulges, or masses. If there is involuntary reflex guarding, we see that with peritoneal irritation, and right side guarding, we see that with cholecystitis or gallbladder inflammation. You're going to palpate the umbilicus and the surrounding areas for bulges or masses, because we know that's a place that is common for hernias. If there's any hard nodules or metastatic nodes, we see that with cancer. Now, the aorta is not typically palpated, and if you see pulsations there, you will absolutely not palpate the aorta. Last, you're going to palpate the urinary bladder. So, if the bladder is distended, you want to make sure the patient has attempted to empty their bladder before you do this. You're going to begin at the symphysis pubis or down in the hypogastric region and move upward and outward. Typically, the bladder is not palpable and non-tender. So if it's distended, tender, it may feel like a smooth round balloon that could extend up to the umbilicus. Your distended bladder can hold quite a bit of urine, and definitely would be an abnormal finding. Now we see a sign of distress, just like others. We consider this an acute abdomen. This is a symptom of intra-abdominal disease. So any perforation of any organs in the abdomen or blood supply, there's large vessels in the abdomen. So we look for the signs of shock, which includes tachycardia, low blood pressure or hypotension, diaphoresis, those signs of peritonitis, severe sharp pain, any inflammation in that space, inflammation of that peritoneal sac that goes around the abdomen. Bacteria can infect the sac as well as anything inside. So the acute abdomen primary is rare. It's usually secondary to an infection of that peritoneal sac or infection of the organs like pancreatitis, a ruptured appendix, peptic ulcer disease, and diverticulitis. Liver disease or ascites, actually, when that fluid sits in the abdomen, that fluid can grow bacteria as well and can cause an acute abdomen. So some of the main symptoms, the abdomen is swollen and tender. The pain, depending on the severity, could be from a dull ache to severe sharp pain. And typically, especially with infection, you get the fever, chills, all those kind of things. But we assess this, take this very, very seriously. It is an acute problem.